Hello everyone and welcome to week 5. This week we'll be covering chapters 9 and 10. The objectives for this week are to identify the characteristics of the aging population, particularly in the U.S. There are 3 age groups for our elderly population. There is old, young old, middle old, and old old. You'll be able to define fertility and mortality rates and how they affect life expectancy. Describe the effects of chronic conditions and physical impairments on older adults. Explain how health behaviors can improve the quality of later life. Identify the 6 instrumental needs of older adults. Explain the concept of diversity as it describes the American people. Explain the impact of a more diverse population in the United States and as it relates to community and public health efforts. Discuss selected socio-demographic characteristics of minority groups in the U.S. List and describe the 6 priority areas of the Race and Health Initiative. And finally, explain the role socioeconomic status plays in health disparities among racial and ethnic minority groups. This week, the items that are due are the Elderly Healthcare Wiki, Ethnic Origins blog, the outline for your advocacy letter, quiz on chapters 9 and 10, and your discussion board. The purpose of the Elderly Healthcare Wiki is to allow you to consider the healthcare system and how it can be more equitable for all, particularly our elderly population. To help you with this assignment, you may use Chapter 9 in your textbook to read about the issues regarding healthcare and the elderly. What I'd like you to do for this wiki is to read the 2 bullet points. One is, many Americans receive healthcare benefits from their employers. Some people pay for their insurance themselves. A significant number of people are uninsured for a variety of reasons. There are many ideas on how to reform the American healthcare system in order to reduce the overall cost of care and to enable more people have access to quality care. Does government have a role and responsibility to address healthcare issues? Should the primary responsibility for individual healthcare coverage rest with the government or the individual? What are some of the policy solutions that people have developed to address the issue of providing insurance coverage for uninsured people? And what are the benefits and drawbacks of some of the proposed plans? The second statement is whether or not to reform Medicare. Medicare is a government program to support uninsured elderly people. It is an important healthcare policy issue. The country's elderly population is rising, and therefore medical costs for the elderly are rising as well. What I'd like you to do is answer these questions based on that statement. Again, what should the government's role and responsibility be regarding healthcare for the elderly? What are some of the solutions people have developed to address Medicare's rising costs? What are some of the benefits to the solutions you have identified, and also identify the drawbacks? And then what services for the elderly, if any, should your local community be responsible for, and explain your rationale. The second assignment is Ethnic Origins blog. And for this, I want you to consider your own race, ethnic, and cultural heritage and how it may influence your own health. So for this, you may use Chapter 10 in your textbook and read about the different impacts of culture on health. And I want you to, again, consider your own cultural background and answer the questions below. Do you see race or ethnic origin as being a help or hindrance when it comes to your own health? Why or why not? What do you see as your greatest health risk? How could the United States improve the healthcare system to ensure access for all? And any other information you would like to share. The third assignment is now you'll be creating an outline for your advocacy letter. So really the purpose of this is to get you to really start thinking about your advocacy letter and to get you to start organizing your ideas on paper. So use the following format to create your advocacy letter outline. Just know that the more detailed you are now, the less work you will have to do later. So the main elements of your paper, and this should be your outline, is what is the health problem? You've already identified this a few weeks earlier when you identified your topic, but now talk about the health problem a little more in depth. Talk about some rates and statistics that you were able to find for the community you are addressing. What do you see as the cause of the health problem? So what is causing the health problem that you identified? Again, the more reasons and causes you identify now will make it easier later on. Talk a little bit about how this health problem affects the community. What are the changes and outcomes that you would like to see? How would you fix your health problem that you've identified? And then last is, how will these changes help the health outcomes for your community? So we'll talk about the older population. The number of adults and their proportions in the total population in the US have increased significantly in the 20th and 21st century. Currently, our elderly population represents 13% of our entire population, which is about 1 in every 8 American adults. And as I spoke about earlier, the 3 main classifications for older adults are young old, which is 65 to 74, middle old, which is 75 to 84, and old, which is over 85. So as I mentioned, the number and proportion of older adults are growing significantly, and they continue to grow. The fastest growing segment of the older population is 85 plus, and you've seen a growth in age. Some of the factors affecting our population size and age is, this is still from the baby boomers age in 1946 to 1964, where there was a huge increase in the amount of babies people were having. In addition to that, life expectancy has continued to increase due to some of the major improvements we've seen in public health. And as a result, people are living longer, which is increasing our elderly population. So when we think about other community health programs for older adults, we have to consider marital status, living arrangements, racial and ethnic compositions, geographic distributions, economic status, education, and housing for our older adults. About 3/4 of older men are married, and just about a little over half of older women are married. Older women are 3 times more likely to be widowed compared to older men. And if you recall from last week or the week before, we talked about life expectancy for adults. And if you recall, the life expectancy for women is generally longer than for men. So as a result, men die earlier, leaving women widowed. So some new concerns as we see our population age rise is lack of retirement benefits, insurance, and lower net worth assets. So how much money do they have at the end? When we look at living arrangements for older adults, it is closely linked to income, so how much money they have, their health status, and availability of caregivers. Over a half of non-institutionalized older adults live with someone. And so these are people who do not live in nursing homes. What they found is that women are more likely to live alone. Only about a little over 3% of older adults live in nursing homes. When we look at who's in nursing homes, you see that 3/4 or 75% of nursing home residents are women. And again, it's probably because men are dying earlier, leaving the women alone and widowed, and it's just too hard to live on their own. And then more than half of nursing home residents are over the age of 85. What we have seen some improvements in the health of our elderly population is that income has improved. In 1970, about 25%, 1 of every 4 older adults live in poverty. Compared to 2013, a little less than 10% live in poverty. When we look at the major sources of incomes for our elderly population, the major source is Social Security. The second source is income from assets, private pensions, government employee pensions, and earnings. Most of the elderly population live in adequate and affordable housing. 81% of the elderly population own their own housing, whereas 19% rent their housing. However, the older adults' homes tend to be older, as they've probably lived in there for the majority of their lives, tend to have lower value, and in greater need of repair compared to homes of people who are younger, which makes sense. People who are younger have the energy and resources to fix up their homes, or as you get older, you don't have those resources nor the ability to conduct minor repairs. So for most older adults, housing represents an asset, so it's a benefit to them to have their home. As I've mentioned earlier, the health status of older adults has improved significantly over the years. So not only are they living longer, but their functional health has been better too. So functional health is the ability to walk, to cook for yourself, to go to the grocery store, things of that nature. And we also see that the chronically disabled have been decreasing. However, the health status is usually not as good as the younger counterparts, right? So it makes sense. Someone who's 80 is not going to be as healthy as someone who is 40. So we look at the top causes of morbidity or death for older adults. And these account for 2/3 of older adults' deaths: heart disease, cancer, CLRD, stroke, and Alzheimer's disease. As you get older, we see that there are more limitations placed on the amount of activity you get. As joints hurt, bones are sore, you start losing muscle mass, it gets more difficult to engage in activity. However, it's almost more important as you get older to continue to engage in some type of physical activity. Also, chronic conditions really put a burden on health and economic status if they're continuing to pay out of pocket for medical costs. And then impairments among older adults are very prevalent. The impairments can be anything from sensory, vision, hearing loss, physical, and memory impairments as well. So health behaviors and lifestyle choices, they generally have more favorable health behavior than younger counterparts. So older adults are less likely to consume large amounts of alcohol or smoke cigarettes or be overweight. But there's still areas for improvement, including increasing physical activity and immunizations. Older adults are the least physically active of any age group. Loss of physical activity due to just getting old. Your muscles hurt, you're sore, you don't feel like it. Also can be due to chronic conditions such as illnesses and disease. However, the physical recommendations for older adults are the same as other adults. So physical activity is very important as you age, and only 11% of older adults meet those physical activity guidelines. When we look at the dietary concerns for older adults, as you get older, you do need a reduced sodium intake, reduced caloric needs. Your body is just not burning as many calories as it was when it was younger. Increased vegetable consumption and increased water consumption. So the 6 instrumental needs that determine lifestyle for people of all ages are income, housing, personal care or hygiene, healthcare, transportation, and community facilities and services. We're going to move on and talk a little bit about diversity in America and the impact of diversity on health. In the US, the majority population is white, non-Hispanic, which is about 62%, whereas racial or ethnic minorities account for 37% of the population. So classifications that are used include race and ethnicity. Race is defined as the categorization of parts of a population based on physical appearance due to a particular historical, social, and political force. Whereas ethnicity is a subculture group within a multicultural society. And there are 6 main features that define ethnicity. Sometimes, though, these terms are interchangeable. We look at Americans of Hispanic origin. Hispanic origin is an ethnicity, not a race. It's the largest minority group in the US. And of those, the people of Mexican origin are the largest Hispanic group in the US. People having origins in any of the Black racial groups from Africa are considered African American. Lately, I've seen a lot of research and studies use the term Black to denote African Americans, since many Black people do not have origins from Africa, where there's some origins in Southern North America and South America. It is the second largest minority group in the United States. More than half of all Black people live in the southern states. Asian Americans are people of Asian descent who can trace their roots to more than 20 different Asian countries. As you can see, there are some of the countries that are included in those classifications. American Indians and Native Alaska Natives are the original inhabitants of America. There's many different Indian and Native Alaskan tribal groups. These suffer from relatively poor health statuses, and amongst all the minority populations, this particular group has the poorest health outcomes. So as a result, there has been a race and health initiative, and the goal is to eliminate disparities amongst racial and ethnic minority populations in 6 of the following areas: infant mortality, cancer screening and management, cardiovascular disease, diabetes, HIV/AIDS, and adult and child immunizations. So we look at some of the health indicators here. So infant mortality, again, are the death rates of infants 1 year and under. And there are significant health disparities amongst racial and ethnic minority groups. So as you can see here, this chart is from 2000, 2005, and 2010. And these are infant mortality rates by race and Hispanic origin of the mother. So in 2000, you can see that the deaths per 1,000 is a little over, it's about 7. But from this chart, you can see the group that suffers the largest infant mortality rate is Black non-Hispanic, and this has been true for all 3 years, 2000, 2005, 2010. You can see that in 2010 there's been some improvement, however, certainly not enough to other racial and ethnic groups. When we look at cancer screening and management, there are 2 numbers here that you see on this chart. The left side shows the incidence, and this is how many new cases of cancer for each of those different ethnic and racial groups. And on the right side is mortality. So what is the number of people dying from that cancer site and by race? And so what you can see here is that on the right side, that still you see Black Americans not only having usually higher incidences in the most case of some of these certain cancers, but certainly on the right side of the chart, it's showing that they are dying at much higher rates from that particular cancer compared to other ethnic and racial groups. Now, many of the disparities have been attributed to lifestyle factors, late diagnosis, and access to health care. So they're not getting the screenings early enough, which relates to lack of health care, and then as a result, the time the cancer is found is at a later stage, and there are much poor health outcomes when you find cancer at later stages. When we look at death rates from cardiovascular disease, it really varies widely. However, again, you see Blacks suffer from cardiovascular disease and stroke at much higher rates than other ethnic and racial groups. And then hypertension, which can lead to cardiovascular disease. What you see is that Black Americans tend to develop hypertension or high blood pressure earlier in life than other racial groups, but particularly than whites. And there are still really unknown reasons why this occurs. Some theorize that the majority of Black people live in southern states, which have high diets, more sedentary lifestyle. However, you would expect to see similar rates of hypertension and cardiovascular disease in white people who live in southern states, and you do not see that. So diabetes has risen in the United States, and this particularly is due to diet and lifestyle factors. So as we are eating poor diets in terms of nutritional value, we also are living a more sedentary lifestyle, which increases the rates of type 2 diabetes. Again, you can see here from age groups and male and female, and this data is from 2014, so a little older. But again, what you see here is that for Black females, they are suffering the highest rates of diabetes, and generally their highest age group is 65 to 74, with Black males second. And then also you see there is a spike in Asian diabetes for the age group of 65 through 74. In terms of HIV infections, again, you see that the Black or African American race or ethnic group has the highest rates of HIV/AIDS infection. And when you look at those numbers on the left, the 10, 20, 30, 40, 60, 70, 80, 90, those are not percentages. It is the diagnosis rate per 100,000 people in the population. So you can see there was a dip in 2011 for most of these, except for American Indian, Alaska Native. However, obviously from the chart, again, Black African Americans suffer from the largest rate of HIV infection and HIV/AIDS. When we look at social determinants of health and racial and ethnic disparities in health, these are the factors that contribute to the health disparities. And so there's a strong association between the social determinants of health factors and health outcomes, particularly in the areas of education, level of income, and poverty. So we look at, how to create more equity in minority health, and there is no simple solution here. What may work for one particular ethnic and racial group may not work for them all. And when we think about some of the solutions, they need to be culturally sensitive and take in the belief system of that culture that they're trying to improve the health. One of the most important aspects is really to empower individuals and communities to be able to improve their own health and the health of the community. And then something known as health literacy. So really understanding different aspects of your own health, being able to make decisions for your own health, and understanding, access to healthcare, how to navigate the system, areas like that. And lastly, when we talk about cultural competence, this could be cultural competencies of our health officials, of our government officials, of our doctors, of our nurses. But it's really a system of behaviors and attitudes and policies that come together in a system, agency, or among professionals that enables effective work in cross-cultural situations, particularly in cross-cultural communications. Culture is vital in how community health professionals deliver services and how community members respond to those services and programs and interventions. This concludes our week 5 presentation. Again, feel free to email me, call me, or visit me if you have any questions. Have a wonderful week.